Hi, this is Elliot Fishman, and welcome to the November 2023 CTisus quiz. I have 10 special cases picked out just for you, and without further ado, let's get started. The differential diagnosis in this 55-year-old female is, well, what is it that I see? I see a cystic lesion by the tail of the pancreas. It has a slightly enhancing rim, may have a faint calcification shown nicely on the arterial phase, axial, as well as the cinematic rendered images. Now, cystic lesions in the differential, you got to think about IPMN. Okay, that's a possibility, though there is a subtle enhancement that's less likely in IPMN. Neuroendocrine tumors, cystic neuroendocrine tumors have rim-like enhancement, can have faint calcification. Mucinous cystic neoplasms can also slightly enhance. They're typically larger. The age range and the sex is good. Remember MCN's, mucinous cystic neoplasms, 50-ish-year-old female. That's a possibility. And so the best diagnosis here is a D, all of the above. Since I know you want to know the right answer, or the best answer, this was actually a neuroendocrine tumor when all was said and done. Cystic neuroendocrine tumors seem to be more common these days. It's something to think about. The differential diagnosis in this case includes, well, what do I see? I see irregularity of branches of the SMA. I see focal dilatation of the SMA, slight irregularity of GDA. So FMD, fibromuscular dysplasia, typically it's renal arteries and carotid arteries, but can involve the SMA. SAM, systemic arterial mediolysis, classically involves the SMA. Aneurysms, dilatation, focal narrowing are all possibilities. And Takayasu's, which is a large vessel disease, Takayasu's most commonly will involve the left subclavian artery, but can involve mesenteric vessels. And so the differential diagnosis includes D, all of the above. The most likely diagnosis in this case is, at first glance, you notice a large mass in the liver and you're about to say hepatoma or maybe cholangio. If this was hepatic adenoma, it would mean that there was transfer into a malignancy like a hepatoma. But then you realize this mass is in the region of the gallbladder fossa. Gallbladder cancer, more common in older patients, 60, 70, and 80-year-olds, can be a focal area of thickening, but can be large and aggressive and directly invade the liver. And although, yes, this could be hepatoma, this was a large gallbladder cancer. There's adenopathy present in the peripancreatic region. I do admit, if I gave you the entire study, you would notice that you didn't see a normal gallbladder and you see this large mass in the gallbladder fossa, and you would have made the right diagnosis. As we note, gallbladder cancer can directly invade the liver. The most likely diagnosis in this case is, well, what do I see? I see a large left paraspinal mass with bony erosion or destruction from the region of the neuroforamina, which might come through there. Now, lymphoma can involve muscle and involve bone, but not this kind of geographic pattern. TB is more destructive, involves the disc space. You typically have a discitis and soft tissue mass. A sarcoma can be a possibility, though typically they're very aggressive. When you look at this case, particularly at the cinematic rendering, beautiful visualization how the lesion arises by the foramen, how it's a soft tissue mass, fairly homogeneous, and so the best diagnosis here is a malignant peripheral nerve sheath tumor. Nerve sheath tumors are typically relatively low density, minimal enhancement, but location by nerve roots is kind of the classic type of appearance. The most likely diagnosis in this patient with weight loss. When you look carefully in this case, what is it that you see on the axial and coronal? There's thickening in the third portion of the duodenum, and I have to worry about infiltration. Lymphoma is a possibility. I don't see adenopathy, but you don't need adenopathy. But lymphoma typically is bulkier. GIST tumors are typically mass-like and eccentric. This is mass-like but infiltrative. And carcinoids are typically vascular and not infiltrative. The best diagnosis in this case is an adenocarcinoma. I will admit adenocarcinoma versus lymphoma can be very tricky. Yes, bulky adenopathy is more common in lymphoma, but we've seen early cases of lymphoma without any adenopathy of note. The most likely diagnosis in this case is, well, what do you see? There's scarring in the left kidney, but the right kidney there's significant scarring, markedly dilated calyces, loss of cortex, and what appears to be a staghorn calculus. When you see staghorn calculi, when you see cystic dilated spaces, when you see stranding, you know you're talking about an infectious process. So lymphoma, this is not going to be. Acute pyelo, you can have stone disease, but you have patchy areas of decreased attenuation and typically stranding, and not this kind of scarring in the acute phase. TB is a possibility. You get strictures with TB, you get a pyelitis, you can have a dilated and thickened ureter, you can have bladder involvement. So TB is a thought, but when I see big calcifications, loss of cortex, I got to think about XGP. Now, I will admit XGP usually involves the entire kidney, which is enlarged with massively dilated calyces and usually no function. But if you pick up XGP early, it's going to look just like this. Though I thought I would share with you an excellent case of relatively early XGP. The most likely diagnosis in this patient with back pain is, well, I see the left adrenal looks good, but the right adrenal is enlarged. There's a soft tissue mass and there's haziness. That's not the look of an adenoma. It's not hyperplasia, and it's not metastasis. Now, metastasis you got to think about gives you a mass, but you usually don't have any hemorrhage around it. And this is hemorrhage. This is adrenal hemorrhage. Now, you could argue, could this be an adenoma that bled? Yes. Could this be metastasis that bled? Yes. But this oval look, typically described in trauma and also in patients with anticoagulant therapy, and this patient was on anticoagulant therapy and bled into the patient's right adrenal gland, a very classic case. The most likely diagnosis in this case, well, what do I see? I see a large mass in the left atrium, extends near the right atrium. The mass has minimal enhancement, maybe a faint calcification. This is not the appearance of a thrombus. It could be a met to the left atrium. I guess that's a possibility. Melanoma. Most of the time when you see mets to the left atrium, they extend along the pulmonary veins. Could this be lymphoma? I guess so in theory, but I've never seen lymphoma as a well-defined round mass only in the patient's left atrium. But the most likely diagnosis is atrial myxoma, a great look for atrial myxoma, a great location, and a really good appearance on the CT scan. The most likely diagnosis as middle-aged female is, well, you see a complex cystic mass. When you look at it, if I gave you more images, but even on these, it really is arising and involving the pancreas. Now, it's not an IPMN, right? This is complex cystic lesion replacing most of the gland. You could think about a serous cyst adenoma. The septations are good for serous cyst adenomas, but just the extent, I just don't like it. Cystic neuroendocrine tumors usually have rim-like enhancement. They aren't this large. What tumors involve the body of the pancreas but can extend to involve the tail and the head, and that would be mucinous cystic neoplasm. I helped you a little bit by saying it was a middle-aged female. Remember, MCNs are in 40 to 50-year-old females. I have to admit, I still could consider a serous cyst adenoma, though I don't like it for that. But this is the most interesting-looking MCN you're ever going to see, and that's the right answer. The most likely diagnosis in this 60-year-old male is, well, you see a mass involving the distal body and tail of the pancreas, and the mass has calcification. If it wasn't a male and if it wasn't 60, a SPEN tumor is a possibility. They're solid masses, they have calcification, have a range of appearances. So this theoretically could be a SPEN, but unlikely. It's not simply chronic pancreatitis with the mass effect. Metastatic renal cell is always a thought. I don't see the entire kidney, so I can't tell if this patient had a partial nephrectomy. But metastatic renal cell can be very vascular, but typically you don't have the calcifications. The tumor that's vascular, that can be bulky, that can be in the tail of the pancreas or body or head, is a neuroendocrine tumor. And this is a very nice example of a neuroendocrine tumor with calcification involving the body and tail of pancreas. So, that's 10 cases. I think there were some really, really good cases. I think 10 out of 10, they were great cases. I hope you got them all right. I hope you learned something, and I hope you have a great day. See you soon. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.